update of Dr. Roshan Parasram, Chief Medical Officer, Ministry of Health, and Dr. Avery Hines, Technical Director, Epidemiology Division, Ministry of Health. I am Al Alexander, Senior Corporate Communications Officer in the Ministry, and I will moderate this morning's conference. We begin with the CMO, who will provide the latest clinical statistics for the parallel healthcare system. CMO.
Hi, thank you, Al. Good morning to the Honourable Minister. Good morning to Dr. Hines, members of the media, members of the viewing and listening public. So, as Minister would have indicated on Monday, I believe, we have a new dashboard which gives you, at a glance, if I could have that first slide, what are the pertinent bits of information that the population and the media has been asking for and we think is relevant at this point in time. So, starting on the top, we look at the population vaccination status. Fully vaccinated, 47.9%. That number gives you, on the left-hand side, you see the green bar, fully vaccinated, 670,167. On the right-hand side, the blue bit, 729,833. These are first doses or no doses at all. Boosters administered to date, 79,086. Our new positive cases on the left-hand side going down over the last 24 hours, 637. Deaths reported yesterday, 15, and condolences to the family of all of those who would have lost loved ones during this pandemic. Total persons hospitalized to date, 609, and that includes patients at the hospitals and step-down facilities. Total active positive cases to date, 15,345. And break down further in terms of the vaccination status of the hospitalized cases. That includes hospital and step-down. Fully vaccinated, 1,363. Not fully vaccinated, 8,973. And that is for the period July 22nd, 2021 to 15th of December, 2021. Looking at the bottom left, again, total deaths to date, 2,951. Total deaths by vaccination status. The bottom bar gives the total number of persons not fully vaccinated. The grey part, 319 on the bottom, indicates deaths prior to 24th of May 2021, and as the text suggests, the 24th of May 2021 is the date at which the first group of vaccinated individuals became fully vaccinated. If you recall, that's the healthcare workers that were vaccinated first. The 158 portion of it is people who were fully vaccinated out of the entire lot, and if you look at the proportion, it is extremely small compared to the unvaccinated cohort. If I could have the second slide, please. And that will basically give you a little more detail in terms of the total patient. Here, next slide. Total patient in hospital, 444. Couva Hospital and Multi-Training Facility, 115. Of those, 25 in ICU, 23 in HDU. Korup Hospital, 45. Augustus Long Hospital, 56. St. Anne's Hospital, 4. Arima General Hospital, 69. New Point Fortin Hospital, 81. St. James Medical Complex, 45. Scarborough General Regional Hospital at Fort King George, 23. And Scarborough General Hospital at Signal Hill, 6. If I could have the last slide, it will give you a little bit more information on the step-downs. And just to remind everyone, these other bits of information are available on our website, although it's not on the dashboard, which you will see. So if I could have the last slide, it will give you step-down transition facilities, 165 in total. At the Claxton Bay Correctional Facility, no one at this time. UE Day Bay, 60. UTT Valsine, 21. Point Fortin Area Hospital, 32. Field Hospital at Port of Spain, 28. No one in the Couva Field Hospital at this time. Tacarigua Facility, 16. And in Tobago, 8. So thank you, Al. That's my brief clinical update for this morning.
Thank you very much, CMO. I now invite Dr. Hines to present the latest epidemiological update. Dr. Hines.
Thank you, Mr. Alexander. Good morning to the Minister, to my colleague, the CMO. Good morning and Happy New Year to members of the media, members of the viewing and listening public. If we can have the first of my slides, we can go directly into the EPI update, and what we will see is that our weekly cumulative data that we've been looking at as we trace and track the progress of the pandemic. And we note that for the months of November into December, we saw those green bars rise in November, reach a peak in December, and we saw slightly lower weekly totals in the last couple of weeks of December. But we do have to bear in mind that some of that may be driven by the testing behaviors, meaning individuals choosing whether or not to go for testing during that holiday period. So we are keeping an eye on that to see if that's a genuine downward trend or whether it is really just driven by testing behavior. And that first green bar, or the last green bar on the right side, is now week 1, epidemiologic week 1 for 2022. So you'd see that there was a shift in the graph. We removed 2020, which was the gray bars we used to see. And we're just looking at 2021 and filling in 2022's data as we move to the right. If we go to the next slide, we'll see the same data again. Now just looking at it numerically and looking at the percentage changes from one week to the next. And we would see what we described before in the last 3 weeks of December. We would see that there was a 14%, then a 3%, then a 37 or 38% decrease from one week to the next. We would hope that that is the indication of a downward trend, but as we said, we know that the testing behaviors may have varied, and therefore we're keeping a close eye on that to determine whether we're really going in that direction or not. Again, bearing in mind the fact that the presence of the Omicron variant globally is one of the threats that may cause an increase at a later point in time. Going to the next slide, we see the same data now for 2020 only, and the first month of 2020. Sorry, the same data for 2021 and the first month of 2022 reflected on monthly basis. And we see that for December, we had accumulated a total of 20,538 cases, definitely highest total for the entire year of 2021. And we are now tracking the progress for 2022. We also note that the positivity would have risen, but we note that that would have been driven by the sampling process, the sampling of individuals at higher probability of being ill, both in terms of symptoms and in terms of exposure. If we move to the next slide, we see that the demographics have, of course, remained largely the same. Next slide, please. And those demographics are mainly that the age and sex distribution hasn't changed significantly, just about 50-50, male-female, and the majority of those cases being in that 25 to 49-year-old age group, that 51% of the total positives falling within that age range. And the last slide, showing the data for the fatalities, we note that, of course, we have that predominance of the older age group. Next slide, please. The older age group, 60 and above, being about 2/3 of the deaths. The male-female balance being slightly in favor of the men, with 57% of the fatalities being among men. And we do note that there have been deaths in younger individuals, all the way down to the pediatric age group. We've had a small number of deaths there, and we continue to emphasize the importance of protecting yourself and your family via the public health guidelines and regulations, and further protecting yourself and your family via having those who can be vaccinated get their vaccines to reduce both their personal risk and the risk of those within their families. So with that, I conclude the epidemiologic update and turn you back over to Mr. Alexander.
Thank you very much, Dr. Hines. I now hand you over to the Honorable Terence Dialsing for the latest vaccination figures and an update on the national COVID-19 vaccination campaign.
Thank you very much, Al. Good morning to the Chief Medical Officer, Dr. Hines. Good morning, ladies and gentlemen of the media, and all good citizens and everybody in Trinidad and Tobago listening in, wherever you are, whether locally or internationally. Let me just update the vaccination figures as of the close of play last night. Total persons fully vaccinated, 671,314. We have reached finally the 48% bar. We are all looking forward to reaching 50%, which will be a good psychological place to be. Total persons acceding to the request to come in to be boosted, 81,633. And we continue to appeal to persons who are eligible to be boosted to become boosted. Yesterday we would have done 2,547 boosters. We can do more, and we are asking persons to come in for that extra layer of protection. That is your booster. protection now, especially as all the data for the Omicron is showing, is that you need not only your first dose, your second dose, but you also need a booster. So let's all get boosted, which will reduce the burden on the healthcare system, but more importantly, help you to save your life, have a safe home environment and a home work environment. On Monday, I did promise to bring the schedule for the next monthly round of boosters, and that round will start on Saturday, 8th January. The current schedule ends on Friday, 7th January. So if we could have that slide, please. Yes. So, booster schedule for 8th January to 5th February 2022. Same procedure. It depends on when last you would have received your final dose of a 2-dose regime, or in the case of Johnson & Johnson, when you got your shot. So for those persons who got AstraZeneca, second dose between the 1st and 9th of July, you will come in from the 8th of January, which is Saturday, and then Monday to the 15th of January. From the 10th to 16th of July, if you got your AstraZeneca second dose. From the 17th to the 22nd of January. If you got your second dose from the 17th to the 23rd of July, you come in from the 24th to the 29th of January. And if you got your second dose from the 24th to the 30th of July, you come in from the 31st of January to the 5th of February. Sinopharm, similar type of schedule, so no need really to go into details and take up time there. Johnson & Johnson, slight difference. The Johnson & Johnson rollout started, I believe, in October, CMO? I believe so. So this second round of boosters for Johnson & Johnson, if you receive your Johnson & Johnson shot between the 7th to the 14th of November 2021, you come in again the 8th, which is Saturday, and then 10th to the 15th. Similar schedule as to AstraZeneca. If you got your Johnson & Johnson 15th to the 22nd of November, you come in from the 17th to the 22nd of January. And if you got your J&J from the 23rd to the 29th of November, you come in from the 24th to the 29th of January. And if you receive your J&J from the 30th of November to the 7th of December, you come in from the 31st of January to the 5th of February. What is important to note for those who would have missed their booster dose for any particular reason in the last cycle, we are in a position to say, come in, we welcome you to come in. If you miss your opportunity, and get boosted now. So you are not out of the loop, you will not be disadvantaged, because many people may have missed the opportunity in December for a variety of reasons. You may have been ill, you may have had the flu, you may have been out of the country. For whatever reason that you missed it, you didn't have transport, whatever, you were tied up with Christmas. We understand that, but we want you boosted. So we are making it very, very accessible for those who missed their original time schedule to come in and get boosted. The booster dose that will be offered to you is on the right-hand column. Any COVID vaccine that we currently have is now available for you to be boosted. As you would recall, WHO would have signed off on this maybe a few weeks ago. So any COVID vaccine which has WHO organization emergency use listing is appropriate for you to be boosted. If you have any questions as to which of the two boosters are best for you, whether it's Sinopharm or Johnson & Johnson, please have a chat with your healthcare provider. There may be individual cases where an individual booster may be preferable for you. Just do that. The sites remain the same, and all of this will be on the Ministry of Health's website very soon. It will be published on some of the newspapers as we did. We ask you to keep it, but it will be on the Ministry of Health website. It will be on social media. And in the face of Omicron around the world, we already have some local cases in Trinidad and Tobago. We are asking persons, give yourself that extra layer of protection by being boosted. So Al, thank you very much. And now we could go on to questions.
Yes, and as we move to the question and answer segment, where we invite members of the media to pose questions to the panel, our media representatives are asked to state their name and the name of the media house before posing their questions. We will take 2 questions per media house during the first round of questions, and we will field additional questions from the media once time permits. Kindly pose 1 question during all other rounds of questions. Also, during this segment, we will be taking a few questions submitted by the Media Association of Trinidad and Tobago relating to the national COVID-19 response. We will take our first question from Guardian Media Limited.
Hi, morning everyone. Rashad Khan, Guardian Media Limited. So my first question is to Dr. Hines. Dr. Hines, on Monday there was mention of the ministry expecting to see a spike in cases coming out of that holiday period because of the movements and gatherings. Do we have any projections as to what that caseload might look like in the coming days? And my second question is for Minister Diyal Singh. Minister Diyal Singh, now that we're getting closer to that safe zone initiation for the public sector, do you anticipate that we may even be seeing some issues related to false vaccination cards by these employees who maybe don't want to get vaccinated but want to keep their jobs? Because I know that has been an issue that we've had over the period of our vaccinations. And with that being said, is anything being done, anything being enhanced, any further measures being put in place to probably pick up on this? Thank you.
So I'll take the second question first. So Rashad, you read my mind, and apparently you were in the meeting we had this morning with, is it ACP Williams or DCP? With ACP Williams of the TTPS, who is on the COVID-19 task force under the chairmanship of the CMO. So we had a discussion this morning with ACP Williams and with all the CEOs on that exact issue, Rashad. So I think you are spot on. And yes, we are instituting further controls and further measures, which I will prefer not to discuss in the public domain at this time, to do just that, to clamp down even further, more than we have clamped down currently on false vaccination cards. We had a long discussion with ACP Williams. Was that all for me?
Yes.
Yes, thank you.
Okay, thank you for the question, Mr. Khan. Now, it's difficult at this point, given what I had just presented in the epidemiologic update, to make projections on how high or how far the spread may reach at this current point in time, given that the trends that we're seeing may actually be influenced more by choices to access testing, and those numbers, while they're showing a downward trend, and we'd like to think that that is the direction in which the epidemic is going, we know better. So we do know that with the additional movement that we would have had during the season, and with the potential introduction of a more transmissible variant, that those numbers are likely to rise. But we'd actually need to see what the numbers are doing or what they look like when we get a couple more, maybe a couple more days or even a couple more weeks of data in, before we can start projecting in a reliable manner the direction in which we think the numbers will go. So we don't want to make a preemptive prediction at this point in time, but we will most certainly keep you updated.
Thank you, Dr. Hines. And Minister, we go to 103 FM. You're ready for your questions.
Good morning, everyone. Sarah Chandu from 103 FM. My questions are for the CMO and perhaps Dr. Hines. First of all, I appreciate this may have been addressed at previous media conferences, but there are still many people in home isolation who are not fully aware of the discharge criteria. So could you please perhaps outline for their benefit and say if any changes are being considered to this policy? And secondly, we are continuing to see double figures every day in terms of COVID-19 related deaths. So is it possible to give us a breakdown in terms of deaths at home versus deaths in hospital? perhaps fatality numbers for the different hospital ICUs and even fatalities for those whose care was being overseen by private institutions? Thank you.
Yeah, so thank you for those questions. So in terms of the discharge criteria, generally speaking, as you know, the CMOH on the top of it has discretion as under my hand in terms of the Quarantine Act. So they have discretion in terms of the length of time. Having said that, there was a national policy that was put out last year that speaks to, for a positive person, the length of time that you should be quarantined based on two things. It's based on the symptomatology and the date of your test. So generally speaking, what we have done, and looking at the national data, is we have 14 days plus a 7-day period, which was implemented a while ago. It's actually being actively looked at by the CMOHs, including the CMOH in Tobago, and they should come back to me with a position on what they have discovered in terms of the local data and the international data as it relates to the period of infectivity of this particular virus. Bearing in mind we have a new variant of concern in Trinidad and Tobago, and we have to keep a very close eye on it. Little is known about the period of transmissibility of that particular variant, so we have to be cautious. So it's more or less at the discretion of the CMOH. It usually is about 14 days plus 7, and it is also based on whether you have respiratory symptoms continuing or not. So a point in time has to be selected, and then they calculate based on that. For the average person in isolation, it goes anywhere between 14 to 21 days based on what they find in terms of symptomatology. For asymptomatic people who have maintained that status throughout, is a little bit less than 14 in some instances. But that's more or less the period we have for now. Dr. Hines?
Okay, thank you for the question. In terms of breakdown, what we have, and we've noted, we updated the data very recently, we're looking at a similar percentage as we had updated before, about 6.4% of the total deaths actually having occurred at home. The vast majority of the remainder then are either in the parallel healthcare system or in the A&Es that are feeding into the parallel healthcare system, and there are very few in the private system, as you would have inquired about. So it's really that vast majority in the health system that we have been speaking about, both the A&Es that provide care pending admission to the parallel healthcare system and the parallel healthcare system itself, with 6.4% of those individuals having been designated as having died at home. So hopefully that gives that some perspective to the proportions in different places.
Thank you, Dr. Hines. We go back to the Minister.
Thanks. Sarah, I want to thank you for raising the issue of home care because Dr. Richards, who is always in contact with the frontline doctors, you may recall, ladies and gentlemen of the media, I have raised this more than once, more than twice at these news conferences, the use of ivermectin. The frontline doctors at the A&Es, when they examine the notes that are based on interviews with relatives and patients, we continue to see, and the doctors have asked me to raise this morning, because they are concerned, appalled, and disheartened by the continued reliance by persons on ivermectin. You have persons who can afford it. This is the information coming to me this morning, who are paying up to $30,000 to be treated at home with ivermectin and home oxygen. What the doctors have asked me to say this morning is that this is untenable. If you are on oxygen at home, we ask you to come in to a facility to get oxygen. And there is no need to spend $30,000 on ivermectin at home. This is the reality that the doctors are reporting to me this morning. Another development, and I raised it on Monday, is the use of something called COVID packs, which they are getting somewhere, which has a combination of ivermectin, vitamin B, and vitamin C. That is not going to assist you. And it is their view that the continued reliance and confidence being placed on ivermectin is contributing in some way or fashion to the number of deaths that we experience. So again, and the CMO is going to write once again to the Medical Association, is it? And the Pharmacy Board about the use of ivermectin to treat COVID-19 patients at home, which is not WHO approved, for which there have been no clinical trials showing its efficacy. And people are dying at home after paying these huge amounts of money for something that is no better than snake oil. That's the best way I could describe it now. So thank you very much, Sarah, for raising the issue and allowing me to raise that particular point that the doctors have asked me to raise.
Thank you, Minister. AZPnews.com, the floor is yours.
Good morning, Praya Bihari, AZPnews.com. And Happy New Year to Dr. Hines. My first question, I don't want to follow up on Sarah's question about quarantine. When someone has to stay in quarantine for 21 days, sometimes the employee, his or her sick leave runs out, and therefore he or she is not paid. My question, therefore, is there anything that the employee can do to be tested, and the testing will be negative, so he or she can go back to work if it's negative? And my second question is, have we had any cases of anyone who has had a third dose or booster and has contracted COVID-19 or has passed away from COVID-19? Thank you very much.
So in terms of your first question, yes, going back to the discharge criteria, right? Last year we would have had a discharge criteria that included a negative test on the outside, meaning that you had to have a negative test before you were discharged. I had asked the CMOHs to consider that as well, reintroduction of a test in lieu of an extended period of time. So that is under active consideration, and something will be coming out as soon as we conclude our data analysis and determination. So for now, we don't require a negative test. What we require is the completion of the quarantine period, which is clearly labeled on the quarantine form, and we're asking the employers to look at the start date and the end date, and once you have passed that particular period, you should be allowed back to work without having to do a test. So that is the present protocol.
Okay, thank you. And with respect to the question on boosters, what we currently do is we are categorizing those who have died as either fully vaccinated or not. We do not, as far as I'm aware, have a case of a boosted individual who would then have passed on, but we would need to review all of the cases just to be sure that there isn't such a case within that database. At this point, I believe the answer is no. But we continue to monitor, and if we do see that, then that would be one of the things that we mention. But we would also like to point out that in the individuals who've been vaccinated, or even in those who've been boosted, the risk of death, while being decreased, is still offset by the fact that many people have very serious comorbidities. And what we're seeing is that among those who were vaccinated and still passed on, there was a combination of advanced age and serious comorbidities that would also have been affecting the outcome. So we do want to continue to encourage individuals to get their vaccination and not to be discouraged by the fact that you may still see small numbers of these cases popping up. The vaccine does provide the protection that reduces the risk of death, and we want to continue to encourage all individuals to access that product and that service to reduce your individual risk.
Thank you very much, Dr. Hines. We go to Newsday for your two questions. Good morning.
Good morning, everyone. Rihanna McKenzie from Newsday here. My first question is regarding outdoor sports. Is it possible for a safe zone policy to be set in place for sports teams where, especially for non-contact sports like cricket, where these sports can resume with vaccinated players and no spectators? My second question, is it possible to have an update on the first Omicron case in TT? Is the person still in quarantine? Has that person been charged? Thank you.
Okay, so I will take the Ministry of Sport question and part 2 of the Omicron question. So let's start. The charging of anybody is a function of the TTPS, not the Ministry of Health. So that question is to be posed to the TTPS. CMO will take the other part. On the issue of outdoor sports, I am aware that the Ministry of Sport is actually working on a policy. So we will work together with them to do same. Thank you.
Yeah, so as I said before, those first few individuals that we reported on, their symptoms were mild in nature. Some of them had no symptoms at all. So that is the update on that. If I could just take the opportunity, in terms of the clinical update, there's a trend. Dr. Trotman has been indicating to me the pediatric cases that we're seeing in the country over a long period of time. And what we have noticed over the last few days, we actually have 8 pediatric cases in hospital today. One of them in a is critically ill in ICU. So we note it as a concern on the back of Omicron and looking on as what is happening in the rest of the world. The pediatric cases are filling up the hospitals in the US, for example, and in some other territories around the world. We are seeing that our Omicron anytime now will become increasing in prevalence. It is about 25% of the variants of concern that we're picking up as of Friday's report, and we expect that based on what happened in other parts of the world that it will actually rise pretty quickly and Omicron may become dominant within the next week or two. So Delta still is dominant as of Friday's report, accounting for about 75% of the variants of concern picked up, Omicron 25%, but we are seeing a slight uptick in the number of pediatric cases, and it is concerning. Notably, 7 out of the 8 are below the age of 12, where there's no vaccine available. There's one person who is within the 12 to 18 age group. So we have to look at it as a concerning statistic, keep our eyes on it, especially in light of what is happening across the globe. Make sure those who can vaccinate your children within the ages 12 to 18, do so as soon as you can to protect those children. Thank you.
Thank you very much, CMO. We now go to the Express for your 2 questions.
Good morning, Camille Hunt, Express. My question is regarding a report we got from a COVID patient who said they were asked to purchase the drug methylprednisolone. Is it typical for patients to have to purchase their own medication, and is there a shortage of this drug?
Thank you. So there is no shortage of methylprednisolone in the public healthcare system. We have both methylprednisolone and dexamethasone. Shipments came in December. So in the public healthcare system, we have both of those corticosteroids. Thank you very much.
Thank you. And we now go to TV6. Good morning. We're ready for your 2 questions.
Good morning, Urvashi from TV6. My questions are for the CMO, Dr. Parasram. Dr. Parasram, of course, you just spoke about the increase in pediatric cases, and in some reports in the US, they're reporting like a 40% increase in pediatric hospitalizations in a matter of weeks. Are you or is the ministry contemplating either allowing the vaccination of the 5 to 12 age group, or are you going to boost hospital capacity for pediatric patients in light of this expectant spread? So that's my first question. My second question, I'm not sure if it was covered in previous health conferences, but there appears to be a public health regulation which bans open air cremations. Can you please explain to us the science behind this ban, Dr. Parasram, and also about there appears to be a backlog in cremations. I'm not sure, I don't think it happens with burials, but there appears to be a backlog in cremations. Can you explain to us how that backlog occurred? And also we're hearing about a mix-up of bodies and so on. Thank you.
3 questions.
Okay, Urashi, good morning and Happy New Year to you. I think this is your first time you're joining us for this year. So I will take most of these questions. On the mix-up with cremation, that issue is a private sector issue with a particular funeral home, so we cannot comment on that. 2, on the issue of open-air cremations, as we have said up to Monday, That matter is before the courts, and a judge will decide on that, so we can't comment on that. On the issue of the 5 to 11s, yes, this is a very important question, Urvashi, and thank you for raising it. So currently in Trinidad and Tobago, we have the Fisa vaccine, which is WHO approved for 12 to 18, or for 12 and above, and we have been doing that. There are 2 vaccines before WHO for EUL or EUA for 11 to 5, both Sinopharm and Pfizer. And I'm glad you raised the issue, because a lot of people are asking, why don't we simply give the 5 to 11 cohort the Pfizer vaccine? We can't, for 2 reasons. One, it is not legally permissible, and is not clinically permissible. Why? Because the 5 to 11 vaccine of Pfizer for that age group is a different dosage of the vaccine, is 1/3 the strength of the adult vaccine. So that is one difference. Difference number 2, it's a minor difference but significant for legal reasons. The buffer that they use, which is an inert ingredient, the buffer that they use to ensure stability of the vaccine is a different buffer for the 5 to 11 vaccine as opposed to the 12 and above. So that's difference number 2. And difference number 3 is a different packaging. So for all those reasons, we cannot use the current stock of Pfizer, which is, has EUA or EUL approval for 12 and over. We have to wait for the EUL or EUA approval for the pediatric version, where the dose is different, the buffer is different, the packaging is different. What I can tell you and tell the country is that we have not been standing still on this issue. We have already placed orders for the pediatric version, and as soon as it is EUL and EUA approved by WHO and the supplies are available, we will bring it in for that cohort of persons, 5 to 11. I think both you and I are equally anxious to start vaccinating those groups, and there are many parents who want that particular group vaccinated. So I hope your questions have been answered.
Thank you, Minister. We go to the follow-up questions. We will start with Guardian Media Limited.
Good morning again, everyone. Minister, I just want to follow up on something we started discussing on Monday when it comes to the home test kits, right? I know you said that it will be approved once there's certain criteria are met and that sort of thing, but I just want to know, will there be any sort of policy from the ministry's end that will come out to support that, to really probably ensure a system that people can report their own results if it's positive or anything like that?
Yeah. Again, Richard, for the second time this morning, you read our minds. We discussed that this morning, so I'll ask the CMO to give you what the current thinking is.
Yeah, so generally speaking, a rapid test is usually an antigen rapid test that is utilized and gives you a very quick idea at home as to what you're dealing with. So you have a turnaround. The specificity and sensitivity, meaning the accuracy of the test is not as good as the confirmatory test, obviously. But what it does, it gives you an idea, generally speaking, based on the type. There are many different types of antigen tests, and they will vary in the effectiveness and the way they pick up COVID-19. So based on the type of test that is utilized, it will give you an idea if you have COVID or not, especially on the back of a high positivity rate that we're seeing. If you have viral symptoms and it turns out to be positive, chances are it will be COVID. So what is most important is that if you are ill and you have a positive result, that you actually follow on in terms of the actions that you need to take to prevent spread from your loved ones and from anyone else in society. So you stay at home, you isolate as long as necessary, and we advise really that you should follow up with a PCR as a confirmatory test, because there are still false negatives and false positives that you can get. So that is the ministry's position as of now. It's not something that we necessarily want to police very heavily in terms of the test itself, but we will ensure that the quality controls are met through the Chemistry, Food and Drug Department before it is allowed use.
Thank you, CMO. EZPnews.com, we are ready for your follow-up question.
Thanks again, Al. CMO, I just wanted to find out the 8 children who in hospital. Do you know what variant of the COVID they have? Thank you.
Sure. So we haven't at least gotten back any confirmation from the University of the West Indies, as far as I'm aware, as yet, that any of them are variants of concern. So if we do, we of course will update the public as necessary.
Let me just go back to flesh out an answer to a question the person had asked about capacity for children. I think I forgot to mention that. Yes, we have recently increased capacity for children using one of the buildings under Heritage Petroleum that quite graciously refurbished that building. And that will house, I believe, 8 children in South Trinidad, but it can be for children from anywhere. We already have some dedicated facilities, including ICU facilities for children in AREMA. And we continue to look at ways to increase capacity for children. But as we always say, the solution is not increasing capacity, because that is finite. The best way to manage this globally is through vaccinations, and now, as you are seeing, they need to be boosted. So a very important point is that need to be boosted. And to date, as I said earlier, only 81,633 persons have come out to be boosted. So a boosted parent, a boosted grandparent offers protection to a little child who cannot be vaccinated 5 to 11. That is the principle of herd immunity. Protect everyone. The herd is to be protected so that that person in the herd who cannot be vaccinated is protected. So a lot of the questions about capacity is finite. And basically, we have more or less reached that point, although we always look for ways to eke out 10 beds here, 20 beds there. But the real solution now is vaccination and boosting. Thank you very much, Al.
Thank you, Minister. And now we go to Newsday. We take your follow-up question.
Good morning again, everyone. All right, so for my follow-up question, I was hoping that CMO, you can respond to NATO's call for clarification on how COVID-19 deaths are classified. I know you touched on this in the past, but NATO is saying they are still confused about the categories of COVID-19 deaths and are calling for clarification of people who have died as a direct result of COVID-19. Can you clarify? Thank you.
Sure. So both myself and Dr. Hines has responded in the past. I'll ask Dr. Hines to clarify. We discussed it. If he can clarify that matter.
Okay, thanks for the question. Now, I think we've gone through this before, but it bears maybe explaining again. The deaths that are being counted as COVID deaths are deaths that have either COVID-19 as the direct cause, meaning the individuals went in and had a COVID-19 diagnosis on admission, succumbed to their COVID-19 infection and were counted as COVID-19 deaths, or individuals who sometimes are found in for example, those who would have died at home. We know that they have COVID, we know that they had other pre-existing conditions, and whether COVID was a direct or a contributing cause to their deaths, those deaths are counted as COVID-19 deaths as well, because COVID played a role. It's also necessary to explain that there are categories that are put onto the death certificate: the direct cause, the pre-morbid conditions, other significant conditions. Any of these that include COVID-19 would then classify the death for our purposes as a COVID-19 death, because there is either a direct link or a contributory link to the COVID infection. We're not counting random individuals who died of something else and happen to have COVID. So I'm not sure where that impression came from, but the deaths that have been classified by the clinicians that are looking at the individual cases have all been deaths of the nature just described. I'm hoping that that clarifies and puts that to rest. I don't know if the CMO has anything that he wants to add to it.
Okay, thank you. We will now move to address some of the questions that Matt has posed. First, has the Ministry of Health monitored persons who have recovered for signs of long COVID? If so, what does that look like and how is it being managed?
Yeah, so thank you. So yes, we have monitored persons. Persons have returned. There was a unit set up in the North Central RHA. Dr. Mohammed was on the program on more than one occasion describing the symptomatology and how they have a multifaceted team that actually deals with those cases. So there's that degree of monitoring in terms of referral pathway that exists as well. So we continue to keep a very close eye on it to see what is happening with regards to long COVID. You have people quite a long time after the acute affection has gone away, 6 months, some of them 8 months, where there's persistent fatigue. Even if you try to walk up a flight of stairs, for example, you feel tired. That is the type of symptoms you're getting back from people. There's what has been described in the literature as brain fog, people forgetting things, being more forgetful than before. So those kinds of symptomatology are hallmarks of long COVID, and we have seen it in Trinidad and documented in the literature as well.
Just a follow-up to that question, can long COVID be considered a disability in the sense of being unable to work? And can such a disability be included in the schedule under the Ministry of Social Development, where at some point persons can apply for assistance?
Yeah, so what I can say is that there's normally guidance given from the public health physicians where they fill out disability forms and the public assistance grants. So they should be approached, that is the physicians in the public health system, to do so if you think you have a concern in terms of a disability, and then it will go to the social work department for that division to make an assessment of it. And if there are any concerns, they will relate to the physician in question. So I don't think it's disease specific, but it is related to the physical concern or complaint that the individual has.
Another, is the ministry monitoring the recovery or death rate of COVID positive persons with vegetarian, vegan, or plant-based diets?
Okay, I think I will attempt to answer that question. It's an interesting one, but I think that there's a distinction that needs to be made between a research study or prospective cohort study in which that sort of data is generally collected and a health system that is treating acutely ill patients. In our health system, we are not generally in the habit of taking a dietary history from all of the patients and then looking at their outcomes thereafter. So that's not something that would be collated or compiled or reported on, because it's not really the domain or the purpose of the treatment that the health system gives to a patient. That would be something you'd look at maybe in a research study long after the actual acute epidemic would have settled.
Thank you, Dr. Hines. Another, despite the Ministry of Health repeatedly stating that Tobago has 9 COVID-19 ICU beds, the Division of Health keeps referring to only 5, the original 5. What accounts for this disparity?
Thank you. So I think I will take that. So I have my figures here. There are 9 ICU beds in Tobago, yes. 5 at the facility in Signal Hill, that is the hospital, and 4 in the accident and emergency. Dr. Richards always points out that the ICU numbers comprise of ICU capacity both in the hospital and in the accident emergency. So it's 5 in the hospital and 4 in the A&E, giving you 9. Okay? Thank you very much.
Thank you very much, Minister. And we will take a question from TV6, follow-up question.
Thank you again. Minister Dial Singh, thank you very much for your responses to my questions before, but I really did want to hear from Dr. Parasram as the public servant, as the Prime Minister would, often refer to him. But since you've taken charge, let's revisit the open air fire cremations. I understand it's before a judge, not a jury, but we're talking about the public health regulations, which are under your pen as minister. It's something that you can change. At least that's what the Hindu community is saying. And they seem to believe that they are being disenfranchised. They are being made to pay exorbitant fees to just, take care of their deceased. And we're talking about poor people here. Don't they deserve an explanation? What is the explanation? Why was this penned into public health regulation that you can't have open air pyre cremations for COVID victims? I think that this is aside from the case before the court.
No, so Urvashi, it is actually very germane to the issue before the court, and I respect your question. But as we always say, once a matter is before the court and is sub judice, it is improper for anyone to speak about it in the public domain. But I do appreciate the concern that you have articulated.
Thank you, Minister. I think I may have missed Newsday's follow-up question, so we'll go back to Newsday. Is your hand still up? Okay.
No, you answered my follow-up question. Thank you.
All right. So we'll go to AZP.
Thanks again, Al. Minister, I want to find out our herd immunity now. We have 48% our population fully vaccinated. What percentage now are we looking, for herd immunity? Thank you.
Thank you, Prior. So the issue of herd immunity from the start of the pandemic to now is one that has evolved, and I will ask the CMO to tell you what is the latest thinking about herd immunity.
So generally speaking, I think even from the WHO standpoint, they had first said very early on that they were looking at 70%, and then that was changed to 80%. What has happened and what has the greatest change that will impact on that number is the variants of concern, the transmissibility that they carry with them, increasing in transmissibility as we saw going from the Wuhan strain, for example, then going to the P1 lineage and following on now with Omicron and then other variants to come. So as something becomes more transmissible, the number of people that you require as a percentage of your population to be vaccinated also increases. If you look at something like measles, for example, you find that you need, PAHO WHO has stood by the childhood diseases that we need to be above 95%, for example, for a childhood disease to be eradicated or even come to close to elimination. So we're looking at, there's no magic number for this particular pandemic at this point in time, at this stage. But what it requires is that every country in the world reach to a significant level of vaccination at the same point before there's a change in the trajectory of the pandemic. As long as there are pockets of unvaccinated people, you will find that variants of concern will tend to develop in those areas. Trinidad by itself will have to try to get its number as high as possible in the shortest period of time so that our hospitalizations will drop and the severity of disease that we are seeing will drop. You may still get cases, you may still get infections, but those needing hospital care, those that are dying from this disease, will end if we get that number to be as high as possible in the shortest period of time.
Thank you very much. Thank you very much. There being no more questions, we are at the end of today's media conference. We thank the media representatives and you, the listening public, and viewing, of course, for your participation. We leave you with two testimonials of persons who decided to take the COVID-19 vaccine. Goodbye for now.
Hi, my name is Monica Raphael, and I'm from Sandy Grande. I took my COVID-19 vaccine to safeguard myself and my family from this deadly virus. I encourage you all to do the same.
Don't delay. Get vaccinated today. A message from the Ministry of Health.
Hello, my name is Atia Adams and I'm from Sandy Grande. I chose to get vaccinated because I wanted to give myself a chance at life, and I would like to encourage you to do the same. Get vaccinated.
Don't delay. Get vaccinated today. A message from the Ministry of Health.
lava, drinking with me whole